Welcome back, Thran. I'm Joe B. Do you have a lower buttock pain that shoots to the side of the knee and aggravated by walking, chair rise, and side sleeping? If so, then you may have a backward sacral torsion, and this video will show you how to deal with it. Let's dive in. A backward sacral torsion, or BST for short, is a sacral dysfunction where one sacral base gets stuck backward or posteriorly, while the opposite and inferior lateral angle, or ILA, gets stuck forward or anteriorly. Picture this. When the right sacral base gets stuck backward while the left ILA gets stuck forward, it is termed a right-on-left backward sacral torsion, where the R pertains to the prominence of the sacral base and the L pertains to the ILA prominence. Conversely, if it is the left sacral base stuck backward while the right ILA gets stuck forward, then it is called a left-on-right backward sacral torsion. A right-on-left backward sacral torsion stems from traumatic events or instances where a heavy load is lifted from the left low side. Picture this scenario: a sudden trunk extension to the right from a flexed side bend and rotated to the left position. The asymmetrical strain caused by this movement pattern can lead to the sacral base on the right becoming stuck backward while the left ILA is pushed forward. A left-on-right backward sacral torsion is just the opposite, where you perform sudden trunk extension to the left from lifting a heavy load from the right low side. Backward sacral torsion can bring about lower buttock pain close to the midline, a pain that shoots to the side of the knee and increases with walking, sit to stand, and laying on that side. The assessment for a backward sacral torsion requires the patient to do seated sacral flexion or arching test, since it makes the dysfunction be more prominent for easy diagnosing. There are two bony landmarks to palpate: the sacral basis and the inferior lateral angles. To palpate the sacral basis, the patient must be in a relaxed, erect, short sitting with the hands across the shoulders and feet flat on the floor. The therapist should be behind the patient with eye level at the sacral base or L5 spinous process. The first web space of both hands palpates the iliac crest first, then both thumbs reach down and medially to palpate the posterior superior iliac spine, or PSIS. From there, the thumbs go up and medially by one finger breadth to arrive at the sacral basis. After that, the patient is instructed to arch the low back, resulting to sacral flexion and lumbar extension. Normal findings are that sacral basis move forward or anteriorly and becomes deep. Abnormal findings will be that the right sacral base stay backward or posteriorly instead of forward and anteriorly, or become shallow. To palpate the inferior lateral angles, or ILAs, the patient and therapist position will be the same as with the palpation of the sacral basis. Both thumbs will slide down from the iliac crest to the PSIS. Then the dominant thumb palpates the S2 spinous process, then S3, and S4. Once S4 is reached, the thumbs will go 2 to 3 finger breadths inferiorly and laterally to arrive at the ILAs. The patient is then asked to perform seated sacral flexion or arch the low back, which results to sacral flexion and lumbar extension. Normal findings are that the ILAs move backward or posteriorly or becomes shallow under your palpating thumbs. Abnormal findings are that the left ILA stay anteriorly or becomes deep. When you have the right-on-left backward sacral torsion, the sacrum is in extension, left side bending, and right rotation. Side bending and rotation are always opposite in this dysfunction. The objective is for the sacrum to oppose that motion by treating it to go to flexion, right side bending, and left rotation. So the treatment is a combination of non-thrust mobilization and thrust manipulation. Patient is in supine with left side close to the edge of table with the hands across the shoulders or clasped behind the head, knees extended. The therapist is on the left side. The therapist's left hand moves the pelvis to the left to cause right sacral bending, then places that hand at the ASIS to stabilize. The right hand is placed on the patient's right posterior shoulder to rotate and flex the sacrum to the left and counter right rotation and extension. Patient is asked to inhale, and upon exhalation, patient is taken to the limit of the range trunk rotation. From there, a high velocity, low amplitude thrust manipulation is provided. Patient may feel a spinal pop or cavitation from this technique. This is performed for 1 to 2 reps. When treating left on right backward sacral torsion, the position, therapist position, and technique will all be opposite of this technique. Then proceed to quadruped right-sided knee drops with left knee over a cushion for 2 sets of 10 reps to encourage sacral flexion and left-sided rotation on that side. Progress each rep to 6-second hold times. So do you want to know how to correct a forward sacral torsion? If so, then this video is for you. Thank you very much.